Good morning, friends. Today we are going to discuss something which is not very common but is exciting, is interesting, and if there is a case in the surgical wards, may not be in general surgery, maybe in head and neck surgery or a pediatric surgery. Normally, they are there as short cases in your MS examination or National Board of Examination. I know today pediatric cases are normally not allotted in National Board of Examination, but there is no hard and fast rule. And children, maybe 10 years, 12 years, are, if they have a swelling, such as swelling, they are brought to you in examination for presentation. Most of these problems are seen in a pediatric age group, and just for the sake of completion, though we in India by and large draw a line 12 years as a pediatric age group, anything older than 12 we do not call them as pediatric. In an international forum, up to the age of 18 is considered as pediatric age group. And in fact, in some of the Scandinavian countries, up to the age of 21, they are called as children, adolescents. So, technically speaking, yes, in our country we call it 12, but it's not true. And most of these cases, Ranula, Dermoid, Cystic Hygromas, manifest by the age of 12 to 15. Maybe once in a while you may get a dermoid, an adult, maybe 25 years, maybe 30 years of age. Now, before we go on to the discussion of these three things, it's relevant to revise the anatomy of the head and neck lesion, especially anatomy of oral cavity and the triangles of the neck. I'm not going to cover triangles of the neck. I think it has been covered when we discussed about blocked sections of the neck, when we covered about neoplastic lesions of the oral cavity. Regarding oral cavity also, I'll only limit myself to the relevant anatomy pertaining to these cases like ranula, dermoid, especially in the floor of the mouth or in the supraoid region. Often question arises, what is a sublingual space? Any space between the dorsum of the tongue or between the tongue and the floor of the mouth is sublingual space. The question is, what forms the floor of the mouth? What forms the muscles of the tongue? Before I go on to the floor of the mouth, I think it's appropriate to revise a little bit about anatomy of tongue. And a tongue has got two groups of muscles, intrinsic muscles and extrinsic muscles. The tongue which we protrude, the tongue with which we taste, the tongue which we rotate inside the oral cavity, mostly has got intrinsic muscles. The extrinsic muscles are not visible at all. The intrinsic muscles are superior longitudinal, inferior longitudinal, transverse, and the vertical. They are the muscles which are responsible for speech, phonation. Is the extrinsic muscles which are responsible for formation of bolus, for mastication, for pushing the bolus into the pharynx or for purpose of swallowing. And the extrinsic muscles of the tongue are styloglossus, which is coming from above. You got a hyoglossus, which comes from a hide bone and goes up to the base of the tongue. Because genioglossus arises from a genial tubercle, and there's a muscle which comes from above, what is called as palatoglossus, which comes from the palate. And barring palatoglossus, barring styloglossus, all muscles of tongue are supplied by 12th nerve. All intrinsic muscles of tongue are supplied by 12th nerve. So, if there is an injury to the 12th nerve, there is not only limitation of the movements, but there is an effect on the speech and the phonation. I repeat, speech and phonation is primarily due to intrinsic muscles of the tongue. And all the muscles of the tongue, intrinsic or extrinsic, are superficial to the floor of the mouth. If that is so, what forms the floor of the mouth? If you look at the two muscles which contribute maximum to the formation of floor of mouth are a mylohyoid on either side, which arises from a mylohyoid line of the mandible and is inserted onto the upper part of the body of the hyoid bone. And on either side is the geniohyoid, which arises from the inferior genial tubercle. On either side is the digastric, especially the anterior valley of digastric. And laterally there is a muscle called stylohyoid, which arises from styloid process. Barring stylohyoid, all muscles of the floor of mouth are supplied by mandibular division of the fifth nerve, be it mylohyoid, be it geniohyoid, be it anterior belly of digastric. So, one has to be clear that tongue is above the floor of the mouth. Having revised the anatomy of floor of the mouth and the muscles of the tongue, comes what are the conditions that are seen in the floor of the mouth. The floor of the mouth has got salivary glands, They are sublingual, submandibular, ectopic salivary glands, and any pathology arising from them often manifests either in the sublingual space or along or between the hyoglossus and the mylohyoid, that is submandibular gland, which is also a part of floor of the mouth. Now, the commonest pathology which is seen in children, which is maybe as early as at birth, but often by the age of 2 to 5 years, may occur even up to 15 years of age, is a swelling in the floor of the mouth. And I think I would like to show a picture of there it is. That's, you see that swelling there? Bluish, translucent. See, it is not in the midline, it is one side of the midline. Under the tongue, superficial to floor of mouth. This is called a ranula because it looks like or resembles the belly of frog. What is the etiopathogenesis of ranula? There are two schools of thought. One is possibly the sublingual glands that does get obstructed and leads to the formation of a cyst, what is called as a retention cyst arising from sublingual salivary glands. Are these glands developed at the birth? Can from those tiny salivary glands one can get such a big retention cyst? So the second possibility is possibly they are not a retention cyst, but they are extravasation cyst. That is, this localized leak of these secretions, and these secretions are mucoid. They are encapsulated and they absorb water over a period of time and result in formation of a cyst.